Welcome to Thayer Presents, a brand agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Thayer and Mickey Urdea.
Welcome to Thayer Presents. My name is Rich Thayer, Managing Partner at Thayer.
And this is Mickey Urdea, founder and partner at Thayer. And today we're going to interview Jen Leib, who we've known for quite some time. She is a registered lobbyist in Washington, D.C. She has a very deep knowledge of the goings-on in the government and policymaking. And she's going to tell us quite a bit today about the things going on with regard to key legislation in Washington and its pertinence to the diagnostics industry.
And now our interview with Jen Leib.
Welcome, Jen, to our podcast. We're very pleased to have you here and look forward to talking with you. Can you start us out by giving us a bit about your background?
Yeah, absolutely. Thank you for the opportunity. I appreciate it. My background, I'm a genetic counselor by training. I spent 5 years at NIH doing clinical research mostly in the neurogenetic space. And then I transitioned to policy through a genetics and public policy fellowship and worked in the Senate for 2 years on the Health, Education, Labor, and Pensions, or HELP committee, which is the committee that has jurisdiction over all health policy issues in the U.S. So I was going to stay a third year because I loved it. And instead I got recruited off the hill by industry. Back in the day, it was Affymetrix. And so I went to the other side of the table and I directed their DC office. So essentially their in-house lobbyist. And I stayed there for a few years until about 2008 when I switched to consulting. So I joke that I am the only board certified genetic counselor who's also a registered federal lobbyist here in DC, at least to my knowledge I am, and have a consulting firm called Innovation Policy Solutions. So we're a government relations and public policy firm here in DC. And because of my background and my colleagues' backgrounds, we tend to really focus in on a lot of the genomics and precision medicine policy issues.
It's been a pleasure to work with you over the years, too. We've had a lot of fun jobs together. So great to have you here.
Absolutely.
So, Jen, let us start out with just talking a little bit about all the things which have changed over the pandemic here. Over the last 3 years, the changes associated with point of care, home testing, telemedicine, wellness, have just been unprecedented. And given where we were before the pandemic, what changes that have been particularly surprising to you?
Yeah, I mean, I think anyone who's interacted with the healthcare system since March 2020 has had the experience of receiving it via telehealth. So that has been a huge, significant change. And I think one for the better. I think both providers and patients enjoy the flexibility that comes with accessing healthcare services through telehealth systems. So that's been a significant change. Yeah. So the telehealth has been a significant change. And I think one that is really tangible for policymakers because they've probably experienced it themselves. And so I do think it's one of those areas that is really ripe to continue on beyond the public health emergency once it expires or is no longer extended. Mm-hmm. Yeah, and I think, in the laboratory space, likewise, too, as COVID testing became something that people did in their home. And before that, I'm sure, lots of adults are probably familiar with pregnancy tests and other over-the-counter tests. But for the most part, people thought about getting infectious disease testing at the doctor's office, not something that you could just do whenever you felt like it in your home. And then the way in which the federal government facilitated that by shipping kits to people was actually very unique. And the first time the government had ever done anything specific like that. And I just saw yesterday that they announced they're going to actually do another round of free COVID tests mailed to people's houses over the next few weeks in anticipation of another surge over the holidays.
Yeah. Do you think any of these changes are going to expand into other disease states as well?
Yeah. So, one of the CDC has some great statistics that they put out. They do their annual report on sexually transmitted disease prevention. And during COVID, the rates of STDs dropped, but it was artificial, right? It was because the rate of testing and screening dropped. The health clinics had to close like everyone else did during the shutdown. And then most of the public health departments in the state and local level had to shift all their resources and all their staff too to responding to the pandemic. So there was sort of this like mini epidemic within the pandemic, at least in the area of STDs. And so one of the recommendations and tools that was really useful during the past couple of years was sending those at-home self-collection kits to patients or the public to use in order to increase the rates of screening for STDs. So I think that was a really good example of that. It's not just going to be for pandemic times, but also perhaps for prevention in other areas as well. One of the biggest changes that I find fascinating from both a practical clinical approach level, but also policy, is the role of pharmacists. Just the way in which the federal government really relied on them to not just do their normal responsibilities during the pandemic, but also to get testing out to the public, get treatment out to the public, including the test to treatment programs that the administration then put in place. And the reason from a policy perspective why that was so fascinating is because historically there's just a lot of competition or an attention between physicians and other types of health providers over the scope of practice, what they can and cannot do. And it was clear during the emergency that at least the administration and quite a few members of Congress looked to pharmacists as they're in the community, there's a lot of them, they're available, and just a huge resource to help with the response. And so I keep wondering, what next? What isn't the next great role for pharmacists, at least in the precision medicine space? And the one that comes to mind is pharmacogenomic testing and medication management based on those results. And in fact, there is language in the Cures 2.0 legislation that was introduced last year that includes a provision that would allow pharmacists to prescribe pharmacogenomic testing and also give medical consultations based on the results.
Jen, you mentioned the increasing role of pharmacists and the important role they played during the pandemic. As I understand it, though, there are things called collaborative practice agreements that need to be in place at the state level. And even at the federal level, Congress for some years now has been wrestling with how to implement legislation to allow across all the states broader opportunities for pharmacists to both provide services and, importantly, to be able to bill for those services. What are some of the acts, or where do things stand right now with longer term lasting engagement of this important segment?
Yeah, so I think reciprocity across state lines for all healthcare professionals, not just pharmacists, is going to be a continued issue of focus and policymakers, because and this isn't the first time it came up. I mean, I remember back, I was actually working in the Senate during Hurricane Katrina when New Orleans was in a bad state, and health providers were trying to get there to help, and there was all these licensure barriers that they were unable to practice across state lines, and they were also unable to get medical malpractice insurance to extend for them if they practiced outside their coverage areas. So it was, this has been an ongoing issue in emergencies, not just in the pandemic. And I'm hopeful now that we're getting a little bit closer to addressing it. And you're right, there's lots of ways in which it can be addressed on the state or federal level. It would be ideal, I think, for the federal government to do something to allow a reciprocity like program across states, because otherwise to do things like compacts or other arrangements that get states to recognize other states' licensure laws, that requires each of those states to pass laws again. At least that, I'm a federal lobbyist, but my understanding from the state level is that you can't just enter these sort of arrangements without having it in state statute that allows it. So I think there's a lot of barriers to that. So the simplest way would be for a federal law to just acknowledge in times of public health emergency or other declaration of a national emergency that health professionals would be allowed to practice across state lines.
The other side of that, though, is the ability to invoice and to actually charge for services, which, as I understand, is covered through provider status legislation, if you will. Where do we stand with that? Is that also something that's decided at the state level, or is there a role for the federal government?
No, and I think correct me if I'm wrong, but I think you're referring to provider status under Medicare. Correct?
Yes, that is correct. Thank you. Yes.
That gets to that scope of practice battle that exists in every non-physician healthcare profession. And so in order to bill Medicare for services, you have to be a covered provider under federal law. And the physicians, understandably, want to keep that turf and own the scope of practice. So they, across the board, typically oppose any attempts for other types of professions to be added as a covered provider under Medicare. And over the years, they have. So nursing, clinical psychologists, podiatrists. Others have been added as covered providers, but the pharmacist bill has been languishing in Congress. But what I think is interesting about their tactic is, while they still have their bill that would be amazing because it would just immediately make them covered providers, they can bill Medicare directly for their services. Because of the pandemic, they've been sort of doing this strategy where they're going and getting like piece by piece, slowly expanding their scope of work on the federal level. And we talked about before with the test to treat programs, the ability to provide treatment for COVID. And so I've been impressed with their advocacy strategy around that, sort of educating policymakers about the role of the pharmacist and the ability of the pharmacist to help respond and provide care. And I think that it's going to really help influence their broader advocacy on the federal bill. They're not the only ones right now trying to get provider status under Medicare. The genetic counselors also have legislation pending on the federal level called the Access to Genetic Counseling Services Act. And there's a House and Senate version, but no movement on the bill otherwise. And the same thing, they're getting tremendous opposition and pushback from the physician groups, including the medical geneticists, about the scope of practice and what genetic counselors should be allowed to do as if they were granted the ability to bill Medicare directly.
Wow, it's fascinating.
So, Jen, what are the changes that have occurred in attitudes and policies of major governmental agencies, the FDA, the Congress, NIH, and others over the course of the last few years based on the pandemic?
Yeah, that's a great question. I think that one of the interesting things was just the recognizing that there's HHS and then there's all the agencies below HHS. So you mentioned FDA, NIH, CDC, others, and the need for them all to collaborate and coordinate and work together when we're dealing with a public health crisis and emergency like we have in the past 2 years. And some of the challenges there where you have CDC developing and manufacturing the first COVID test that has to be regulated by FDA. There's a problem with the COVID test. FDA can't get access to CDC campus, like literally physically can't get on campus to try to address what's happening. So just, I say that lightly, but there were much more complicated issues that the agencies all had to work out and navigate and what each of their roles are. And then even looking at NIH, they created the RADx program to try to develop, point of care rapid testing, and just the interplay between RADx and FDA as well. So I think there's just that was one of the biggest, I think, lessons learned is the need for all the agencies to have better coordination and ability to work together to solve some of the issues we have.
Yeah. We've worked with a number of the RADx companies, and that interaction between the NIH and the FDA has been very clear and quite beneficial to those who are in the program. It's worked nicely. Do you think that these changes will carry on, or was it a bubble within the pandemic and we go back to normal now?
I think some of it is definitely going to carry on. I mean, I think especially because, there's next year, I think there's going to be a lot of looking back in Congress, a lot of oversight, looking back on what, not just, most of the oversight will probably focus on funding that went quickly out the door, the federal funding for the COVID response. But I do think there's going to be a lot of oversight also on the agency response. So I think Congress is going to continue to pay attention to it. So I don't think it's going to go away just yet. And then, monkeypox, fortunately, kind of burned itself out quickly and wasn't the level of a pandemic the way COVID-19 was. But I do think, we saw the FDA responding really rapidly, putting out policy right away to get tests on the market, work with manufacturers. I mean, you saw the lessons learned already incorporated right away in their response to that. And that was very reassuring to me. But we still haven't solved the data issues. So the sharing and reporting of cases and other health data to coordinate across the state, local level as well. So, county, town, et cetera, all the way up to the federal level, and the need to improve our and have some consistent data reporting on outbreaks. So, there's still, some lessons saw them being implemented right away, and it was great to see. And other lessons, I think the federal government still needs to figure it out.
It's very interesting that we saw, to your point, a change in our ability to conduct surveillance on SARS-CoV-2 as laboratory tests gave way to home tests. And then we had so little reporting, and we still do, but that we don't really know what the heck is going on. Think something can be done about that?
I
Or will be?
do. Yeah, I think that's actually one of the main focuses. There's a bill that is being championed by Senators Murray and Burr called the Prevent Pandemics Act, and it passed. It's got bipartisan support. It passed out of the Senate committee, and I saw Murray put out a press statement earlier this week calling for it to be enacted by the end of the year. And that in a big section of that bill does focus on the data reporting challenges that occurred during the pandemic and the need to address them. So, I think there's a great opportunity there for Congress to take action over the next 1 to 2 weeks, or hopefully next week, because right now they're hopefully recess on the 23rd before the holidays. But if they can take action and get Prevent Pandemics enacted into law, I think that would be a huge step forward to addressing the data concerns that still persist.
Jen, you referred earlier to the telemedicine market here in the United States. And as I understand it, the CARES Act is only valid or only active during times of health emergency. Are there any acts before Congress to either perpetuate the CARES Act or perhaps supplement it with maybe the Connect for Health Act or the Telehealth Modernization Act or another one that would make these changes more codified or permanent?
Yes. In fact, this has widespread support. It's one of the few issues I'd say in the last year that has tremendous support across the House and Senate and across stakeholders. I saw a sign-on letter sent to the Hill earlier this year with almost like over 300 national organizations signed onto it, calling for Congress to pass the Telehealth Extension Act. And then you see a lot of lawmakers in the last few weeks calling for Congress to do it before the end of the year. There's statements being put out that if Congress fails to enact that extension by the end of this year, it's going to be one of the top healthcare priorities next year. So I feel pretty confident that we're going to see an extension to the telehealth waivers. And so the CARES Act and other the bills passed early in the pandemic allowed the agencies to be able to use waivers and sort of pause regulations to allow the different types of services and access to care to continue. And so those telehealth waivers will expire when the public health emergency expires, and everyone is focused on extending them. And so the most likely extension will be a clean sort of 2-year extension to the waivers beyond the end of the pandemic, or beyond the end of the public health emergency. And then the idea is that those 2 years will give Congress time to determine the best legislative approach, how to make them permanent. And the reason why there's some hesitant to make them permanent immediately is some members of Congress, and in particular, Congressman Doggett, who's on Ways and Means Committee, and others have expressed concern about the need for guardrails and other protections in any permanent extension of those waivers to make sure it doesn't result in tremendous amount of fraud within Medicare and things like that. So there's some members of Congress, I would say across the board, everyone pretty much supports an extension of the telehealth waivers. Before they're made permanent, there are quite a few members who want to see some guardrails put in place to prevent any inappropriate use of telehealth services.
We've been hearing through colleagues around the world surprise and sort of welcome change that self-testing has been adopted as well as it has been for SARS-CoV-2 testing. Seems to have worked very well. Consumers have become comfortable doing it both in the US and many countries around the world. How do you see that perhaps influencing the desire to open up the over-the-counter market opportunity, or perhaps FDA's purview of that, to enable the availability of more testing to support telehealth or self-testing as part of telehealth?
Yeah, I mean, I think, like we talked earlier, I think the public really loves it. I know I like knowing. So I had dinner with a mentor of mine last night who's 84, and I just liked, for my own well-being, though I could test myself before I saw him just to protect him. So I think home testing is great. And I think people are really interested in it and other opportunities for other conditions, whether it's flu or RSV, everything going around right now. My sense is FDA's been let me take a step back. My sense is that FDA views over-the-counter at-home testing as one of the highest risk tests out there, because there is no health professional involved, and because the public, consumer, patient is going to be interpreting that result, him or herself, and then taking action based on it. I think there's just a lot of concern about the safety of those tests before they're on the market. So I see that as a regulatory high bar. But again, it's sort of like the telehealth. You can't put the genie back in the bottle. People love it. People are like, this is great. I don't have to go to the doctor. I find out in 15 minutes. I mean, I think it's just such a huge advance that people really integrate into their lives. And so the regulators are going to have to figure out, where is the balance there to make sure that we don't stop innovation in that space, and make sure patients have access to safe, high quality tests at the same time.
Yeah, we're seeing evidence or support for at-home or self-testing for pre-exposure prophylaxis or PrEP in the HIV community, and it would seem to us that could quite readily extend over to STI. You mentioned earlier about the STD outbreaks, the explosion that's happening now. What are you hearing about the possibilities of opening up self-testing and over-the-counter even further for STDs?
Yeah, so I know right now that you're able to do, I would say right now, the current FDA regulation does allow at-home self-collection, and then you send the swab or whatever the collection kit is back to a lab for analysis. And that is actually currently allowed. And I know there is a CDC report and others that pointed to the ability to use self-collection kits at home during the pandemic was a huge asset to making sure we're still addressing and responding to the needs of other epidemics like in the STI space. But I'm concerned that option is going to go away. And there's another piece of legislation that Congress is actively considering right now at the end. When I say right now, I mean December 2022. And that's the Ballot Act, which would change the way in which all laboratory tests are regulated in the US. It would bring all laboratory tests under the purview of FDA. And one of the big carve-outs in the bill is a grandfathering clause that says if your test currently exists on the market, you're offering it when ballot is enacted, then you're grandfathered. You can continue to offer that test as long as you don't make any substantive changes to it without seeking FDA review. So it's a significant part of the bill because a lot of the tests are currently on the market. We don't want to have to create sort of this testing cliff where they all go away. However, in the grandfathering clause, there's a carve out that says that it does not apply to at-home testing unless the collection kit itself is authorized for use for that specific lab test. And most of the collection kits for saliva, the swabs, et cetera, are not, they're FDA cleared devices, but their label does not reference specific tests. And so the concern is that if Ballot Act were enacted this month, that a lot of the current access to at-home self-collection of samples and then sending it to the lab for analysis, that actually would go away.
There are a number of companies that are looking at blood collection, for instance, very simple, painless, like Tasso and Eurobio and others. Will that then be a problem as well for their case, that they'll have to be married specifically to tests?
Will that be blood collection by a health professional, like a phlebotomist, or are you talking about pricking your finger? And
it's a self-collection. You put it on your arm, it takes the blood, and then it can be shipped. So no healthcare professionals required.
Yeah, that would probably not fall under grandfathering and would require FDA review in order to continue to use that.
Yeah.
It's the self-collection of the kit itself and how that kit is labeled. And the saliva kits that are out there, they're FDA cleared, but I don't know that if any of them are labeled with a specific test in mind. It's probably very few.
Right. What other aspects of the Ballot Act should we all be aware of?
Yeah. So for those who don't know what the Ballot Act is, it is legislation that is bicameral and bipartisan that creates a new medical product called in vitro clinical tests, or IVCTs, that encompass both in vitro diagnostic test kits and laboratory developed tests. So instead of having, right now, there's sort of this two ways to bring a test to market. You can either do it as a box and shipped manufactured test kit, or as a test that is developed, validated, and performed in one laboratory, a laboratory developed test. If Valid Act were enacted, both of those would be renamed IVCTs and subject to a new regulatory pathway at FDA specific for IVCTs. So they would be regulated the same way. And so Valid Act has been, to date, it's been introduced in both chambers. As I said, the House of Representatives has taken no action on it since it was introduced. But the Senate, there actually has been quite a bit of activity, especially early in the summer, when the Senate Help Committee had a hearing on the FDA user fee reauthorization program. And in their legislation for that reauthorization, they included the Valid Act. So there was a committee markup or vote that voted the FDA reauthorization package out of committee, and it included the Valid Act. So a lot of stakeholders on both sides, those who support the Valid Act and those who oppose it, were pretty focused on the Senate because it seemed like there was a vehicle and it was moving and it could become law. But in the end, Congress couldn't reach agreement on the user fee package. The House bill is very different. It did not include Valid. And the government was approaching the end of the fiscal year on September 30th, and they needed to pass what's called a continuing resolution just to keep the government open. So it was a resolution that funded the government based on existing levels. And they used that continuing resolution, or CR, as the vehicle to pass the FDA user fee reauthorization, which also was set to expire on September 30th. And more than half of the FDA's budget comes from user fees. So it would have been very, very dramatic if that didn't get reauthorized on time. But because of the process of the CR, they did not include anything controversial. So no, what we call riders, or a bill that sort of rides along with the broader legislative vehicle. They didn't include any riders in that. And so the Valid Act was stripped from the CR in September. That CR actually expires tomorrow. The Senate should be voting today to extend the CR to December 23rd to give Congress another week to figure out the fiscal year 2023 spending bills and keep the government open. And so that's the next vehicle to attach the Valid Act to. And it's probably going to be the last piece of legislation that Congress passes this year, last major vehicle that Congress will pass this year. So the lobbying for and against Valid Act right now is pretty intense here in DC. And in the next week or two, its fate will likely be decided.
If it passes, what are the implications for both laboratories and IVD manufacturers?
Yeah. So it's a win for IVD manufacturers because it lowers the regulatory bar that they currently face. So right now they're treated as devices, and they either have to do pre-market review or a 510K clearance. Under Valid Act, there's for moderate risk, low risk tests are exempt, but for moderate risk tests, there's a new pathway called technology certification, which essentially is you demonstrate, you get one test pre-market review by FDA, you demonstrate your ability to produce a high quality test. And then any other test that falls within that same type of test or test group would then be deemed appropriate for you to offer. So you can offer it under that certification order. So that's a huge change for the industry. For those offering laboratory developed tests, it's going to be a very dramatic jolt if Valid Act became law, because suddenly they will all be subject to FDA review, which is right now they're not. And so, again, it'd be either whether it's a pre-market review process or that technology certification pathway I just mentioned, or if they'd be exempt, either way, they now would be subject to FDA review. So it'd be a huge change for the LDT space.
What are the implications for the FDA itself then? Will they have to have more staff? Will they have to change processes?
So stakeholders who have I don't want to label them as opposing the Valid Act, but have significant concerns about the Valid Act being enacted in this very expedited manner by being added to a federal funding bill. That's one of their big concerns, is the issue of resources at the FDA. And, they look at the FDA's own data, before the pandemic. In 2018, FDA authorized 3 in vitro diagnostic devices. In 2019 and in 2020, each of those years, it was 7. And then, Concert Genetics has its report that just looks at distinct individual genetic tests on the market, and they say there's over 160,000 right now. But if you look at what happened during the pandemic, from February 2020 to December 2021, FDA received 3,400 emergency use authorization requests, which is about 150 a month. And on December 6th, just a couple of weeks ago, FDA reported that they've they have issued approximately 400 EUAs for tests and collection devices. That means, there were 3,400 at the end of 2021, assuming more people submitted applications this year, and FDA only processed 400 of those. So and if there's hundreds of thousands of tests on the market that suddenly are going to come under FDA review, a lot of people are really concerned about the FDA's resources and their ability to handle the review of all the LDTs, or I guess I should call them IVCTs if the VALID Act were enacted. The VALID Act does include a user fee. So it would set up people who submit the applications, companies, academic medical centers, the labs will have to pay the user fee to the FDA. But yeah, that's one of the big concerns. Does the agency have the resources to truly implement the VALID Act, or is it just going to cause bottlenecks and delay in access to tests because of the review times?
Wow.
Yeah, I think there's a lot of people, again, stakeholders who support the VALID Act will point to the exemptions in the bill, saying that there's lots of different types that are carved out, and so we shouldn't be too concerned about the bill. But I always like to point to those because I think that's where some of the biggest weaknesses in the VALID Act are. In particular, in the rare disease space, the humanitarian exemption is incredibly small. The Orphan Drug Act designates an orphan disease as it affects 200,000 people or fewer. The VALID Act right now is set at 10,000. So its definition of rare disease is pretty low. But the big concern I have is that the exemption only applies to tests used for diagnosis of rare disease, so not screening. So that means newborn screening programs, their tests would be subject to the VALID Act. And I mean, those state public health programs, they don't have the funding. I mean, Congress has failed to authorize the Newborn Screening Saves Lives Act. They actually don't even have a federal authorization right now for their programs. And so I do worry about public health programs like that, like the newborn screening program being, and how it will be, what kind of regulations will be subject to under the VALID Act. And so I think there's a lot of implications like that in the bill. It's a 250-page bill, like 43,000 words, very complex legislative text. And there's lots of things like that in there that really worry me, that we don't truly understand what the downstream implications of the VALID Act is going to be on the current way in which laboratory tests are used and accessed in the country. And I worry, once VALID Act gets enacted, if it gets enacted and how it's implemented, that we're going to see we're going to hit these sort of major walls that we need to fix quickly. And I think newborn screening is one of them. I'm worried about whole exome and whole genome sequencing for pediatric patients with an undiagnosed disease, because in those instances, you don't know what you're testing for. You're just thinking something's going wrong here. Let's do a whole genome or whole exome. Let's see if we can figure out what's wrong with the kid and hopefully save their lives. And that would be considered screening. So I don't think those tests would also be exempt under the VALID Act. So I do worry about implications like that, especially around some of the exemptions. And then the other concern I have with the VALID Act, and again, doesn't matter if you're pro-VALID or against VALID, I think these are valid concerns about the VALID Act, is that there's tremendous discretion given to the secretary throughout the bill. So what that means is, even though it's clear what's written in what would ultimately be the statute, the federal law, if it's enacted, there's all this wiggle room built into it, so that at any point the secretary or the FDA commissioner, the government can change its interpretation of that. And so they can either narrow or expand the requirements or however it is. So again, if we're going to do a dramatic overhaul to the regulatory system that's in place now, we want it to be predictable and understandable. And given the amount of discretion that's in the bill, I do worry that it's going to be hard to anticipate exactly how it will be implemented and what the impact and what it will mean for labs until we see it in practice.
Right. So, Jen, are there any other exemptions in the VALID Act that we should be aware of?
Yeah, there's an exemption that was the language for which was just released a week or so ago. That would be an exemption for academic medical centers. A lot of the stakeholders that both the provider groups, so physician groups that represent health professionals that work in clinical laboratories, as well as the universities and academic medical centers themselves, are concerned about their ability to comply with the VALID Act, given the resources it would take. And more importantly, they view themselves as sort of working within the practice of medicine. So they don't view themselves as manufacturers and an entity that should be regulated by the FDA. They view what they do as a medical service that they're providing. So they're really concerned about the ability to comply with the law if it were enacted. So as a compromise, the Senate committee staff released language last week that included an exemption. It's very narrow. It would essentially only apply to lab tests performed in a CLIA lab in the same physical location as where the patient is being treated. So where the physician ordered the test and collected the sample. As well as that test can't have any other commercially available version of it. So it's incredibly narrow. So a lot of people look at it as they're going to leave it just toward inpatients only. And then again, if the test that's commercially available isn't the most up to date or a version that reflects the latest science, then does that mean you won't be able to develop your own test that does? So the academic medical centers are not happy with that exemption right now. So it doesn't appear to be something that would win their support. But it is something that we heard the people who do support ballot, namely AdvaMed, would be okay with. So both sides are sort of fighting over this exemption. And we're also hearing that some of the bigger reference labs don't support the exemption, but for a different reason, is that they feel that that the academic clinical lab should not be exempt from the requirements if they're not. So it's creating all of this fighting. And so I think something that was proposed a week ago that the Hill staff and the pro-valid stakeholders thought would be sort of this gift to the other side and would win their support, and then valid would sail through, is actually sort of blowing up all the negotiations. So it's been interesting to see all the different stakeholders' position shifting based on this new exemption that's being proposed. And part of me wonders if, when your podcast is published and whether or not valid is law or not, if this exemption is what's going to, in the end, tank the entire bill.
Wow. Very interesting. So we've come through the last few years here in the pandemic, and lots of lessons have been learned. What do you see changing that will help us prepare for the next pandemic, which is inevitable?
Yeah, I mean, I'm hopeful that some of the lower hanging fruit, like we mentioned earlier, the data sharing and reporting systems. There are some states who require that results be faxed, and some health departments who can only report through faxes. And I mean, it just, in this day and age, it's absurd that that's the case. I think given pandemic doesn't respect borders, whether they're state or country or otherwise, that we can't have these siloed reporting systems. So, something I think more on a federal, national level, so that we have access to data. I know throughout the pandemic, a lot of scientists were turning to Hopkins system, and I'm glad it existed, and it was helpful to have their data and numbers of cases, but that's something that I think is a really important role for the federal government to do. So I'm hoping the CDC moving forward will fix those issues and improve the reporting requirements and ability to share data and report. I think one of the other low-hanging fruit we learned was stockpile. We were not prepared. We didn't understand. I don't think we stockpiled exactly the right things. The ability to disseminate what's in the stockpile based on localities where the outbreaks were. I think there was a lot of lessons to be learned around that, around the failures of the stockpiling program and its ability to, even just get PPE to health professionals, right? I mean, it was just at a broader level, and I don't know if the legislation can address this, but I think something that is going to be looked at as Congress looks back at the past 2 years is going to be messaging and public health communication around pandemic. And we all know the story of the masking, like, don't wear masks, don't take them away. In the beginning, health providers need the mask, don't hoard masks. So then, months later, we put on your mask, you need to mask everywhere. So I think there's just been some failures on a simple level as that, but then also on a broader level, like just understanding what it means. But yeah, so, personally, when we have probably everyone's realized during the pandemic just how well we can function remotely and how poorly we can function remotely. So I think looking at schools and workplaces and that and how in the future, what type of policies will be in place looking at that, I think is an interesting area as well. In terms of countermeasures, I mean, the vaccine, mRNA vaccine, and we had tremendous scientific accomplishments in the last 2 years. The sequencing results, the ability to track emerging variants, wastewater surveillance. I mean, I think the science that came out of the pandemic, I think it was just incredibly stunning and impressive to see how quickly the scientific community was able to help develop tools to combat the outbreak. So that I hope that really that investment and that acknowledgement and awareness and continues, because I'm sure you're reading the same articles I am about, mRNA vaccines now for cancer and just other applications. So I really hope that the investment that took place in the scientific community over the past years continues on as well.
Yeah. That was a 10-year overnight success.
Yeah.
All that work that had been going on in mRNA vaccines just was not getting anywhere until this occurred. And then, my gosh, it was the most important thing.
Yeah.
Truly amazing.
As a lobbyist, I'll add that I've worked on bills that take forever to become law. Like the Genetic Information Non-Discrimination Act took 13 years. It was pending in Congress 13 years before it got enacted. So I'm used to taking forever, but I think I was blown away at how quickly and rapidly Congress could pass legislation, sweeping bills, right, at the beginning of the pandemic to put in place the waivers we talked about, just, make sure people had basic needs, but also just in our realm in the diagnostic space, like, the ability to get a code for a new test and get it priced and placed on the fee schedule can take a very long time, as you know, Mickey. And man, CMS did that in like 48 hours. So it's just knowing that when there's a will, there's a way. The processes don't need to take as long and be as complex as they are, I think was really eye-opening for me as well.
Yeah. Just hope we learn those lessons and act more quickly.
I hope so. And I think we have in many ways. I think Washington has its own way of figuring it out. But I do think things like the telehealth waivers and addressing the data sharing, I think all of those will be on the agenda for next year in Congress, and that you'll see some really positive policy coming out of the Hill.
Very good.
Very good.
So one of the other issues actually on the table right now that Congress is looking at is the years ago, the Protecting Access to Medicare Act created a new market-based pricing system for diagnostics. And it turns out with a lot of laws, once they get implemented, they don't work as they intended, or as they create problems we didn't anticipate. And PAMA is one of those in the way in which lab tests are priced. So there's been an effort to do PAMA reform legislation, and there's a bill called SALSA, which I think is a great name, but it's the Saving Access to Laboratory Services Act, or SALSA. And so there's a huge push by laboratory stakeholders to get that added to this end of year package that Congress is working on. Unfortunately, the bill is too expensive, and Congress has to pay for or offset everything it passes. So they're not going to include it. But what they are going to do is a 1-year extension. So another 1-year delay to the reporting requirements under PAMA, and then more importantly, to the cuts under PAMA. So labs would have been looking at, up to a 14% or 15% pay cut next year. And so that at least will be delayed 1 year. And the reason why they're able to get that in the bill is for some reason, a 1-year delay to implementing PAMA actually saves the federal government money. So they're going to use, so anything that saves money, the Congress wants to put in the bill right now. So we'll get the 1-year delay, likely, very likely, but that will set us up for next year. Again, the broader conversation around PAMA reform and what that should be.
Very interesting. It's not obvious to me how delaying it saves the government money.
I have no idea, because the Medicare is going to be paying tests at a higher rate than they would have been otherwise. And the only thing I can guess, it just must be the administrative burden of collecting and analyzing the data that's required to be reported by the labs. That there just must be some accounting that the Congressional Budget Office factored in that's not very obvious to all of us.
Fascinating.
Yeah.
Well, Jen, thank you so very much for your time and for all your comments and your very deep understanding of so many issues going on in Washington. I think this has been very helpful to us, and we hope to our listeners.
And thank you for all your hard work to make the very complex legislation on the Hill more accessible and understandable to the lay audience. Thank you.
My pleasure. It's nice to see you both. And again, thank you for the opportunity. It's always nice to have a conversation about policy with non-policy makers. It's fun.
Very good.
Thank you.
Thanks again.
Holteras Presents is produced by Holteras Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Holteras Associates is not responsible for any errors or omissions or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Holteras Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Holteras Presents.